Hello and good morning. On the morning's AHP session, psychological issues before bariatric surgery. I'm Adam Guralczyk. I'm consultant surgeon in Homerton Hospital in bariatric and emergency surgery. I want to welcome all presenters and moderator, Ms. Rachel Aguilo, consultant in Homerton Hospital, and my colleague, Mr. Kulendran Maitan, who is our surgeon fellow. First presentation will be by Dr. Dennis Ratcliffe, who is a consultant clinical psychologist specializing in working with bariatric patients in NHS and private sector in London. She's author of a guidebook, Living with Bariatric Surgery, Managing Your Mind and Your Weight. She's also author and co-author BOMS guidelines for psychological support before and after bariatric surgery. Dr. Dennis Ratcliffe.
Thank you for inviting me to be part of the conference today. I've opted to do a pre-recorded version of my talk, so I'm going to hand over to the tech team and hopefully they'll be able to play it. Thank you for inviting me to be part of the conference today. I'm going to do two talks in this study day. So this morning, I'm going to focus on psychological issues that people experience before bariatric surgery. And then this afternoon, I'm going to do a session focusing on the issues that tend to arise afterwards. So I'm firstly going to think a bit about what are some of the psychological issues that people considering bariatric surgery commonly experience, and then how are these issues relevant to the process and outcome of surgery. I also want to touch on the role of the psychologist and the assessment in the process, and also think finally about what, when and how should psychological intervention be provided. So first of all, rates of mental health difficulties are significantly higher amongst people living with obesity than in the general population. And in a few slides, I'm going to talk a little bit about some of the reasons for that. But what we know is that the lifetime prevalence for at least one mental health disorder in the bariatric population is about 70% compared to about 46% in the non-bariatric population. And there have been lots of studies which have looked at the prevalence of different types of mental health conditions. And what we see is that overarching theme that mental health difficulties are more common in this group, but if we break it down, the top three conditions that people tend to experience are depression, binge eating disorder, and anxiety, and that's been a fairly consistent finding amongst lots of research that's been done. What I would say is that amongst these studies, none of them really take account of the psychological treatment or the medication that somebody may be receiving, so there could well be an underestimate. I think we also need to consider complexity so that anybody who works in this area will know that people usually don't just present with one difficulty, they come along with a few different issues that they're experiencing. And so, for example, we know that people often experience depression and anxiety at the same time. They may meet criteria for anxiety and binge eating disorder. So the research doesn't quite map onto the sort of complexity that we see in clinic. I think that the diagnoses don't always capture the story in clinic either. So people often present with difficulties that don't necessarily fit into any neat sort of labels or boxes. So some of the things that people often present with in clinic and that I'm often helping them with or we're working on together are things like really high levels of shame and the development of sort of internalized stigma and self-critical thinking, which is such a common experience amongst people living with obesity, and which then has an impact on their eating and so on. Lots of body image concerns, challenging relationships with food, so using food to regulate or manage emotions, lots of feelings of failure, so people blaming themselves for not succeeding or feeling that they haven't had enough willpower, feeling trapped by their weight, lots of experiences of neglect and unmet needs, which tends to go alongside prioritizing and caring for other people. Lots of abuse and neglect, which is often disclosed for the first time in a bariatric clinic. And one of the things that's important to mention about that is that these are examples of ACEs, so adverse childhood experiences, and there's really strong evidence that these are strongly linked with the development of obesity itself. So in terms of these psychological issues, are they a cause or a consequence? So what we know is that there's a bidirectional relationship between obesity and mental health. So the experience of obesity itself often leads to mental health difficulties. It's an independent risk factor for the development of depression, for example, but also the experience of mental health difficulties is associated with obesity as well. So the arrow goes in both directions. And one of the things that I think is really, really important and comes up very often in clinic is the experience of weight stigma. And that is a real mediating factor between obesity and mental health. So the experience of living with obesity and feeling judged and stigmatized often leads to the development of mental health difficulties. And in my experience, it's often associated with lots of shame and has an impact on eating behavior. So people may get into a dieting and binging pattern as a result of it. There was a really important study that was done by Kelly Friedman in 2008, where she gave people a weight stigma questionnaire to complete. And so basically people had to indicate how often they'd experienced certain weight stigmatizing experiences, and for each one standard deviation increase on the questionnaire, this was associated with a 3 times increased risk of binge eating disorder, even when BMI and weight was controlled for. So stigma itself was associated with binge eating disorder. One of the things that I did want to show you is just how we put the pieces together in a psychological formulation, and so how we might help somebody make sense of their past experiences, what they've learned from those, and how they impact on the here and now. So for me, there's something far more powerful about using this information to guide an intervention rather than purely looking at whether somebody meets a diagnostic criteria, say for binge eating disorder or depression. So this is somebody who I'm currently working with at the moment, who has struggled with her weight from an early age and had lots of experiences of feeling different because of this. And feeling that she really stood out at school. She got into a habit of making lots of comparisons with her peers and concluding that she shouldn't be the size that she was. There was lots of shame about her weight as well. So whenever topics came up at school in certain classes like biology or whatever, then she would feel like a whoosh of shame come over her and would feel that she was the focus of everybody's attention. She started to diet from an early age, and this was sort of encouraged by her parents, but it partially triggered a bit of a rebound. So she started to eat secretly. She recalls her father calling her a couch potato, and it became difficult to eat in front of him and others, as she feared that it would trigger negative or critical comments. The beliefs that she learned about that as a child were that eating in front of others is shameful. It's likely to trigger critical reactions from certain people, so it's better to eat away from visibility in order to avoid this reaction. But then she started to secret eat, and the binge eating became a problem, which then led to further weight gain and so on. She also developed the belief that I need to lose weight to make others proud. I need to prove myself. But in contrast to that, she was also thinking that there's more to me than my body. And so it was difficult for her to make sense of that. In terms of how that plays out in the here and now, and the sorts of things that we're thinking about, at the end of the day, when she comes home from work, she'll go to her bedroom, she'll watch TV, and she'll binge eat in secret. her weight increases, and she experiences a further increase in shame, stigma, and feeling that she needs to hide away from other people's comments or other people noticing her. And so the whole pattern gets reinforced time and time again. And so this for me is a really powerful way of helping people make sense of their past experiences and how it might be impacting on their emotional reactions and their eating behaviour in the here and now. And as I said before, it can really start to guide our interventions. So we also need to think about whether psychological difficulties predict post-op outcomes. And as I've mentioned before, there's lots of difficulties associated with purely focusing on diagnoses themselves. But putting that aside, you know, if we look at the research that's been done, it's very inconsistent. So the pre-op difficulties that people experience don't necessarily map onto the development of post-op difficulties, particularly in the short term. The research is very mixed. So lots of studies are showing some associations and lots of studies aren't showing those associations. So it's quite difficult to draw very clear conclusions from this. There was a really important study that was done by Fisher in 2017, which is part of the LIBSS study, which is the longitudinal assessment of bariatric surgery patients being done in the States. And they followed patients up for about 3 years after surgery. 57% of those patients had a mental health diagnosis that was sort of identified prior to bariatric surgery from their health records. And what was really interesting is that the patients with mental health difficulties had the same weight loss as those who didn't have those difficulties. And I think that's really important information, because I think historically there has been a real tendency to discriminate against people with mental health difficulties coming into the process and making predictions that they may have poorer outcomes. So this is a really important study, I think, in terms of demonstrating that the pre-op mental health difficulties shouldn't prejudice against people being considered eligible for surgery. However, what this study did show is that pre-op severe depression or anxiety or bipolar or psychosis is associated with higher follow-up levels of A&E visits and hospital days, and people with higher rates of mental illness tended to drop out from treatment. For me, there's something about being really conscious of our own biases through this process and recognizing that improvement is a valid outcome, and that people going into this process may not have the ideal outcome, but they can still derive benefits, and it's really important to consider that. So thinking about the role of the psychologist, as I mentioned before, there's poor empirical evidence which has identified outright contraindications. There's consensus evidence about active substance misuse, recent deliberate self-harm or suicidality, and unstable mental health at the current time obviously being cause for concern. And for more information, I'd recommend that you look at the ASMBS 2016 psychology guidelines and the BOMS psychology guidelines from 2019. What I would say though is that generally the outcome that we're thinking about is that we're not saying to people that it's an outright no to surgery, but more that this isn't the right time and these are the issues that need to be addressed first before surgery. Because based on the evidence that we have, I think it's very difficult to say that somebody should be ineligible for surgery on a permanent basis. For me, it's more about stability and timing and what needs to happen first. So thinking about the psychology assessment, what are we actually trying to figure out with the assessment? So it's not about whether somebody's suitable or not suitable. For me, it's much more about how does this person's mental health or emotional difficulties impact on their eating and weight? How might this person's difficulties impact on their ability to make and maintain long-term changes required and engagement with the service? And then what recommendations can we make to the team to facilitate their work as well? What are the risk factors for this individual? And then alongside that, how do we mitigate these risk factors or reduce their impact? And actually, really importantly, what are the strengths that this person brings to the process as well? So for me, it's much more about the psychology assessment being an opportunity to identify strengths and vulnerability factors and to facilitate a process rather than being a gatekeeper. In terms of the psychological input before surgery, what we're trying to do with this is identify previously unidentified difficulties and unmet needs. So, for example, ADHD, untreated depression, and so on, manage risk factors, increase preparation for surgery through behaviour change, helping people develop ways of managing their relationship with food, and create space for other interventions to be effective as well. So does psychological intervention pre-op lead to changes? Well, there is good evidence for the impact of psychosocial interventions, particularly CBT, on eating behaviours and psychological functioning, so depression, anxiety, and so on and so forth. So there's good evidence that these interventions reduce psychological distress. There's poor evidence that it's going to directly impact on weight loss itself. So for me, the role of the psychologist is to provide interventions that will reduce psychological distress and help people make better use of the weight loss treatments that are available. In terms of the timing of interventions, the strongest evidence supports early post-op intervention. And it's really interesting that this doesn't really map onto NHS service configuration or resources, but that's a whole other discussion. So just to conclude, we can recognise that there are high levels of psychological distress amongst those seeking bariatric surgery, that there aren't any consistent psychological contraindications that have been identified, and that pre-op psychological factors don't consistently predict post-op weight loss, especially short-term, but they are a risk factor for difficulties post-op and poorer long-term outcomes, both in terms of weight and psychological outcomes. And that the role of the assessment is to identify risk factors and mitigate, consider the timing of surgery, and plan for post-op psychological input. I hope you found this talk helpful. I'm happy to take any questions. Thank you.
Thank you. Any questions?
If we have time, I'm just wondering, what are your thoughts on actually, I know you've looked at various psychological conditions on like neurocognitive measurements of psychology. Have you ever looked into that, Denise, at all?
Yeah, not personally, but I'm aware that there is quite a lot of literature around that, and you know, particular sort of frontal lobe working, executive functioning, and that sort of thing. And certainly if you look at, there's some literature showing that there are higher rates of, for example, ADHD amongst people seeking sort of bariatric surgery.
I think it links with your work very well, I think, because it shows that there is a brain process as well as a psychological process.
Definitely. I think it's really difficult with some of these things to sort of figure out cause and effect as well, because I think when people start to struggle with their weight, actually the impact of that struggle starts to impact on behavior, and then behavior obviously starts to impact on weight. So trying to disentangle things becomes quite complicated.
Yeah, okay.
I remember a year ago, we had in our department the issues when one of the psychiatric team asked us to evaluate their patients for surgery. And there was a lot of concerns from surgical side surgeons that these patients always smoking, you know, it affects the anastomosis, they will not follow up. What would be your general message to surgeons, bariatric surgeons, but not only the bariatric obesity medical professionals, how to take those patients on board without this probably unconscious bias.
So is your question about how do you work with people who might have mental health problems as a surgeon, or how do you,
the research you showed is contradicting that we should actually be more.
I think it's a really valid point, actually, and it is something that I've experienced quite a lot when I've been working in MDTs, that I think often surgeons or other members of the MDT can be quite worried and concerned about working with people who struggle with their mental health, and that implicitly informs the decision or the way that they treat people. And so for me, there is something really important about getting this message out there that mental health difficulties don't necessarily impact in terms of how people might lose weight after surgery. But I think there is something about the way that the team sort of might need to communicate, or perhaps make a slightly more tailored treatment approach for people going through the pathway. Okay. And bearing in mind that engagement for some people might be more challenging.
Okay. All right. Thank you, Denise. There seem to be a lot of questions, but what we'll do is we'll just carry on with the talks, and then we'll give you the questions at the end. Is that okay?
Yeah.
Okay, so next I'm going to introduce Guy Holt, who's an associate nutritionist specialising in weight management and metabolic surgery, and he works in the East Midlands Bariatric and Metabolic Institute, and he's going to inform us about dietary assessment of a bariatric patient. Thank you, Guy.
Okay, thank you. I'm just going to load my slides. Can I get a thumbs up if you can see that?
Yeah, that's good.
Okay, great, thank you. So thank you for the introduction, and firstly I'd like to thank the organisers for the opportunity to speak at such an event today, and also thank you to the panel for coordinating the session. So yeah, I've been asked to speak with you about the dietary assessment of a bariatric patient today. So as we know, the assessment of obesity in the people that it affects is often complex and multifaceted, and that the assessment and preparation for bariatric surgery requires multiple professions working together alongside the patient to optimize the safety and improve the health-related outcomes after surgery. So the preoperative role of the nutrition professional can be summarized as the following: to support and advise lifestyle behavior changes for healthy weight loss before and after surgery, to provide a detailed assessment of nutritional status, including biochemical screening for nutritional deficiencies, aiming to reduce the development of post-operative nutritional complications and unwanted symptoms, and also to optimize the patient's weight loss and health after surgery. So the dietary assessment should cover a wide range of factors, with the overall goal of discovering where the patient has come from, where they're at now, and also where they would like to be in regards to their diet, weight, and their health. And this should include, but it's not limited to, eating stability, body composition, nutritional status, general health, and also knowledge of surgery that the patient might have. So when the individual presents in an assessment clinic, we know two things: that they live with obesity and they've been referred for weight loss. However, when we look underneath the surface, there are often numerous deep-rooted and interlinking factors that have each had a part to play throughout the person's life. And I'm sure that we're all familiar with certain scenarios and similar scenarios to these on the screen with the patients that we work with in regards to their diet history, in terms of diets they've tried before, often short-term and unsustainable diets, stigma around their obesity and weight loss, genetic factors such as genetic predispositions, previous failures, in regards to weight loss or sustainable weight loss that may lead to a resistance to change in the future, weight cycling and yo-yo diets, excuse me, poor health, mobility issues, trauma and abuse, as we've just heard from Denise, depression, and also medication. So the dietary process, assessment process, can be categorized into the subgroups on the left. We can use anthropometric measures to establish baseline measurements and to measure the progress going forward. Weight is by far the most widely used measure, and along with height can be used to attain body mass index, and the level of obesity can be graded. Certain body circumference measures can be used and are useful to indicate things like body shape and fat distribution, as well as calculate the risk of things like metabolic syndrome and cardiovascular disease. Body circumference measures can also be useful when there's a presence of things like lymphedema and water retention, and things that may often skew the changes in body weight. There are more detailed and accurate measures of body composition, such as biological impedance and DEXA scanning, that may be considered gold standard when it comes to body composition. These are rarely available to the masses for use and are often quite expensive. Hand grip strength may be a less conventional or less thought about measure, but can be a useful indicator of changes to strength and changes to muscle mass, both before and after surgery. The biochemical screening is used to highlight any active nutritional deficiencies that the patient might have that could be compounded by weight loss surgery, as well as also indicate organ function. Any deficiencies that the patient has at that time should therefore be rectified before weight loss surgery. So the past medical history and current disease status should be assessed with a focus on conditions that may affect nutritional status or dietary intake and vice versa. The prognosis of certain conditions may be of use and maybe need to factor in, for the planning and suitability for surgery in the future. And identification of certain medications that can influence weight is also important, along with any active treatments that the patient might be going through at that time. It is likely that the patient has tried multiple times to lose weight in the past through a variety of different ways. It is useful to get an understanding of these and the patient's experience with different diets or weight loss programs in the past. A current diet history or dietary recall should help to understand things like meal regularity, portion size, balance, snacking, and fluid intake. This can also be an opportunity to discuss typical eating habits and identify the barriers that may exist in relation to behavior change to move forward. Patients may have a good understanding, may not have a good understanding, of even the basic knowledge of nutrition and mainly some education on things like food groups, balance, and perhaps even cooking skills. And the other things that could influence dietary intake may exist, things like allergies or diet intolerances. These may be important to discuss, especially when using things like lactose intolerance as an example, and how this may affect the compliance of the early post-operative liquids diet. Many of us nowadays take over-the-counter vitamin and mineral supplements. It might be important to understand if these have been advised medically or these have been self-directed by the patient. We should seek to understand not just the patient, but also the world that the patient exists, and that social factors can often be a major influence to behavior change and dietary choices. So, for example, a person's work pattern, if they're employed, if they work shifts, for example, this could affect how their daily routine and also sleep pattern and sleep hygiene. The patient may also require regular care or support due to a mobility or a physical issue, and therefore meals might be have to be prepared for them or shopping bought for them. The patient may also be receiving regular psychological or psychiatric support and other input from specialist teams in the community. So more objective measures should be used to indicate a patient's nutritional status as part of the entire dietetic assessment. The BOM's preoperative nutritional guidelines recommend that all patients undergo biochemical screening for these deficiencies, especially given the higher instances of such in the obese population. Screening tests can include, but are not limited to, full blood count, ferritin, folate, vitamin B12, vitamin D, calcium, parathyroid hormone, as well as liver and kidney function. Assessing protein status preoperatively is also important, given the desire to limit the loss of lean body mass post-operatively. Therefore, highlighting those more at risk of excessive lean body mass loss, if able, is important. There are specific health conditions that should be considered that may influence the type of bariatric procedure or even the suitability for surgery in general. Care should be taken with health conditions that are associated with malnutrition and how risk can be mitigated after surgery as to not compromise the person's nutritional status further. This may also affect the type of advice, dietary advice given, as often other specialist teams are involved with the patient's care. The specific plans may need to be put in place in the pre, peri, and post-operative periods for these types of patients. And this often involves healthcare professionals liaising with other members of specialist teams. We can see on the screen some example conditions. So diseases of the gastrointestinal tract, like inflammatory bowel disease and celiac disease, These are often already associated with effects on nutrient absorption and can cause other side effects, such as abdominal bloating, diarrhea, and sickness, all of which can affect dietary intake and also be part of the post-operative side effects as well. It's important to understand which part of the gastrointestinal tract might be affected, particularly when it comes to selecting the type of bariatric procedure and whether it's a malabsorptive or purely restrictive procedure. Patients with end-stage renal disease often have to follow strict fluid restrictions and may also be advised to limit the intake of foods high in certain nutrients, such as potassium, and that dialysis patients may have higher protein requirements and experience significant fluctuations and changes in body weight both before versus after dialysis. So other factors that should be considered include vegetarian and vegan diets and assessing protein consumption, along with certain at-risk micronutrients that might be lacking in these types of diets. Especially with a focus on vegan diets, we should make sure that nutrients like protein, iron, calcium, and certain B vitamins are met. Vegan diets may also be low, and not just in protein quantity, but also quality, as was discussed in one of the AHP sessions yesterday, and may contribute to the loss of lean body mass after surgery. So care should be taken in regards to procedure selection and discussed with the patient in such cases. We know that cultural dietary variation can significantly affect nutritional intake, and this should be well understood in order to provide advice moving forward. And also understanding the eating habits during periods of religious fasting is important and should be discussed with the patient in how this may affect life after surgery. Casual or social alcohol consumption should be considered in relation to overall calorie intake, lifestyle change, and also preoperative weight loss. However, things like alcohol use disorder and dependence are a contraindication to weight loss surgery and would need addressing before being considered. This may also affect nutritional status and increase the risk of malnutrition. Patients should also be coached and understand there may be a potential elevated risk of alcohol dependence after bariatric surgery. So it's important for the patient to understand the underlying mechanisms of action and anatomical changes after surgery and how these may relate to the dietary changes that they may need to make. So for example, early satiety and reduced hunger levels can mean that the patients may often forget to eat or even be put off from eating, especially in the early post-operative phase. A reduced stomach capacity restricts the portion size and can increase the chance of abdominal pain and vomiting or regurgitation after eating. The reduced exposure of nutrients to the small bowel, as we see with malabsorptive procedures, may give rise to an increased risk of nutritional deficiencies and also a reduced calorie absorption. And increased food transit and rapid gastric emptying can affect the absorption of certain foods and nutrients, as well as the osmotic concentrations in the small bowel, in turn causing symptoms after eating, such as dumping syndrome and reactive hypoglycemia. So once the patient has an understanding of these mechanisms, the eating behaviors may become more clear. And this is the role of the nutrition professional to advise and support the patient on making the necessary changes preoperatively for success afterwards. So going into the table, a regular meal pattern can help achieve adequate nutritional intake with the presence of gastric restriction, early satiety, and malabsorption. A slow pace of eating and chewing food well will support the tolerance of food and reduce the common side effects, such as abdominal pain and vomiting, as well as help the patient to recognize when they are full. A healthy, balanced diet opens up a wider variety of nutrients with a focus on protein intake for the early post-operative healing and also to minimize lean body mass losses. And choosing things like lower glycemic carbohydrates can help to prevent post-operative complications like dumping syndrome. It's also important for the patient to understand calorie versus nutrient-dense foods, which may help reduce the risk of post-operative weight regain and also avoid nutritional deficiencies. And that separating drinks and meals is often important because of the reduced stomach volume and to avoid certain side effects, as well as having small sips regularly throughout the day and avoiding carbonated drinks. So the preoperative patient journey to bariatric surgery is not always a straightforward one. And just because someone may be eligible for surgery, this doesn't necessarily mean that it's a suitable option for them. A patient needs time to be able to make the necessary changes to the diet to prepare for surgery, but also to contemplate life after what might be an irreversible procedure. Each patient may present with different challenges, and therefore should be approached on an individual basis with the offer of regular support and input to implement change. Goal setting is often an important part in the preoperative preparation and can also help measure success. It is therefore important to focus on the modifiable factors that the patient has control over, and also aim to focus on sustainability and consistency with these things. So we've just had a great talk from Denise, and I know she included as to whether psychological issues are a causal factor or a consequence of obesity, and in relation, it's actually a two-way street. But we do know that severe mental instability and active eating disorders are contraindicated in terms of surgery, not lifelong, as Denise said, but also maybe just it might be a timing thing, and a tier 4 service at that time may be inappropriate for such patients. But psychological factors such as comfort eating and stress can hinder someone's ability to implement certain changes, and therefore referring to our psychology colleagues may actually complement the work of the nutrition professional and see that the patient is accessing the support from the right members of the team. Comfort eating may be a cause or an influence to weight regain after weight loss surgery, even with the absence of hunger. So the patient should understand this, and also this should be identified in the preoperative phase. So I thought it would be worth discussing and mentioning very low calorie diets and medical therapy for weight loss, as these can be used in the preparation and optimization of the patient's health before surgery. So significant calorie reduction may help to improve and control glycemic control in the patients living with type 2 diabetes or for those at high risk. It's usually achieved using meal replacement products for a period no longer than 12 weeks at a time. And also the emerging GLP-1 based therapies for weight loss may also help to mimic the post-operative appetite reduction and early satiety, requiring the patient to adapt their diet to ensure adequate nutrition, which may give us and the patient an indication as to how they may respond should they have bariatric surgery in the future. The resulting weight loss may help to reduce abdominal adiposity for those patients with a higher BMI or with marked central obesity, thus making surgery technically easier for the surgeon to perform. And that both of these treatments require quite intensive dietetic support and may be an important part of the overall assessment and workup for surgery. So the last slide from me, and just to summarize, is that we know that obesity is a complex condition, but it has the presence of both modifiable and non-modifiable factors. The nutrition professional plays an integral role in the bariatric MDT, and a comprehensive dietary assessment should cover many factors and components. It is therefore our role to identify, advise, and support on the modifiable dietary factors with the aim to reduce nutritional complications after surgery, but also to optimize health post-operatively, as well as understanding the patient's current nutritional status and highlight those that may be at a more nutritional risk after surgery. Thank you for listening.
Thank you very much. Quite extensive work and monitoring after bariatric surgery for these patients. I remember a couple of years ago, actually, I clashed with one of the metabolic doctor, dietitian. How long, what we are talking about, the lifestyle modification diets, because the diet, the word, is quite restrictive. If someone is going on diet, probably at some point would like to get out of diet. But are those patients aware that this is for life, that they will be for life? You know, we as a children, we were eating more sweets. Now as adults, we like something that we don't like. What is your approach? What would you like to suggest those patients that they will be, and they will accept the fact that they will be on lifestyle modifications and that control for life?
Yeah, I think that should always be the focus. And I think trying to get out of that diet mentality that a lot of people seem to be in leading up to what can be sort of an extensive history before they might show up in an assessment clinic. And understanding that, I think we were having a discussion before the session went live, but the weight loss surgery is actually a small part of the patient's journey, and that the dietary preparation isn't about going on a diet to reach a certain target and then you're fine. it's also there to support what is a potentially irreversible, but also a lifelong procedure. So therefore, the effects in terms of the patient preparation should be there to support that, to where it doesn't necessarily seem like it's a change anymore. It's more like a new normal.
Thank you. Thank you very much.
Thank you.
Shall we go on to introduce our next speaker? It's Dr. Aparna Govil Bhaskar. She's a high-volume bariatric surgeon from Mumbai. She works at the Global Hospital, which is part of the Apollo group of hospitals. And she was one of the first surgeons in India to receive the Centre for Excellence for Surgeons in Bariatric Surgery for her unit. And she's written a book called the Silver Book on Sleeve Gastrectomy, and she's going to educate us on implications of bariatric surgical operations on nutrient absorption. So I'll hand it over to you, Aparna.
Thank you so much, and thank you for the kind introduction. Can I share my screen now? Yes. Is it visible?
Yep, can see.
Yes. All right. So thank you very much for the invitation. And I would really like to thank the organizers for having me here. So it's really a pleasure to be a part of this meeting. And I am a surgeon, but I believe that nutrition is a bigger part of bariatric surgery than the surgery by itself. So my topic for today is implication of bariatric surgical operations on nutrient absorption. We all know that benefits of weight loss post-bariatric surgery are overwhelming for patients living with obesity, and there is a lot of improvement not only in terms of weight loss, but also in terms of associated diseases like diabetes, high blood pressure, the metabolic diseases, the mechanical effects on joints, and so on, the quality of life, and even a lot of psychosocial benefits like we heard just before. And the only thing here is that these operations, with all the benefits that come with them, there may be a nutritional price that may be needed to be paid for the weight loss that we are aiming for. So that could be the trade-off. And as bariatric teams, we all must be committed to minimizing or actually working relentlessly to delete this cost altogether. And above all, I think whenever we help somebody in the field of medicine, I think the dictum has to be to do no harm first. We all also know that the population that is living with severe obesity also is the other spectrum of malnourishment, and there are many pre-existing nutritional deficiencies that are already there. And this could be because of higher intake of high-calorie processed foods with poor nutritional value. We all know that obesity today is seen a lot more in the lower socioeconomic strata, and that could be one of the reasons because they are not able to find food with high nutritional content. And of course, because of obesity, there could also be sequestration of fat-soluble vitamins like vitamin D in adipose tissue. There is also increased production of inflammatory cytokines like TNF-alpha, interleukin-6, leptin, hepcidin, siderophore, lipocalin-2, and so on. Then there could be gender differences. And by and large, obesity is a low-grade chronic inflammatory state which disturbs the absorption and metabolism of certain nutrients. And it is known that a lot of patients with obesity have pre-existing deficiencies in terms of iron, in terms of vitamin B12, in terms of vitamin D3, and so on. These could vary from country to country or between various geographical regions. But yes, they do exist. And in our setting, we see vitamin deficiencies, vitamin D deficiency in almost 70 to 80% of patients, vitamin B12 in more than 50%. Iron is a very, very common deficiency seen in Indian women. So these are deficiencies which are already existing. Now, before we go on to the implication of the surgery and the surgical procedures on nutrient absorption, I think it's important to do a little recap of the GI tract. So we know that the digestion of food basically begins as soon as we take the food bolus in our mouth, which helps us to break up the food particles. And then the salivary amylase mixes with the food. The saliva moistens and lubricates the food, and then it passes down through the food pipe into the stomach. Now, when we talk about the stomach, I think it is one of the most important organs that need to be studied by bariatric nutritionists, because in almost every bariatric procedure, the stomach size will be reduced, barring the gastric band, which is not that common anymore. If we talk about the standard procedures, we have the sleeve gastrectomy, the Roux-en-Y gastric bypass, the one anastomosis gastric bypass, or the BPDDS. All these procedures will lead to reduction in the size of the stomach, either by bypassing the stomach or by resection of the stomach, like we do in sleeve gastrectomy. So stomach, the function is basically to store and churn food, and the food bolus actually undergoes trituration to about particles which are as small as 1 millimeter in size. It is then mixed with hydrochloric acid, gastric lipase, mucus, intrinsic factor, gastrin, and other proteases. And the food stays inside the stomach for about 1 to 4 hours, and then it is passed down into the small intestine. Now, it is also important to understand the cellular structure of the stomach. Here, if you see on the left-hand side, the stomach has the cardia, the fundus, body, antrum, and then the pylorus. Fundus and body are the regions where we have parietal cells and chief cells. Parietal cells are the ones that secrete hydrochloric acid as well as the intrinsic factor. Now, intrinsic factor is very important for vitamin B12 absorption, and hydrochloric acid, of course, is very important for overall digestion and for absorption of certain nutrients, which I will come to later. Chief cells are responsible for secretion of pepsinogen, which is important for protein digestion. Then in the antrum and the pyloric region, we have G cells that secrete gastrin, we have mucus cells that secrete mucus and pepsinogen, and we have D cells which secrete somatostatin. So this is the whole thing about the stomach, and it's very, very important to know what the stomach is doing in for our digestion. So not much of absorption takes place in the stomach, but yes, a lot of important steps of digestion begin in the stomach. Once the food passes down from stomach into the duodenum, it mixes with the bile and, of course, the pancreatic enzymes. Pancreas will also secrete hormones like insulin, which regulate blood glucose levels. It secretes bicarbonates, which neutralizes the stomach acid, trypsin and chymotrypsin, which help to digest the proteins, amylase, which helps to digest the carbohydrates, and the lipase, which digests lipids. Once the food passes down into the jejunum and the ileum, the process of digestion is almost completed. In fact, most of the nutrients are absorbed by the time they cross the mid-jejunum. Most of the water is absorbed in the small intestine. So about, I think out of the 8 to 10 liters of fluid that passes through the GI tract on a daily basis, about 80% of it is absorbed in the small bowel itself. There is also peptidase, which digests the proteins. There are sucrases, again, which digest sugars, and amylase that digests polysaccharides. And then the ileum is where the vitamin B12 mainly will get absorbed. So this is mainly the anatomy of the GI tract and what happens at every juncture. Now, duodenum and proximal jejunum are the primary sites of bowel absorption. So most of you would be familiar with this particular diagram. So if you see over here, duodenum and jejunum are the places where most of our nutrients are getting absorbed. And all the surgeries that are going to be bypassing the duodenum and jejunum, the patients will be subjected to deficiencies of nutrients that get absorbed in this area. So these could be calcium, phosphorus, magnesium, iron, copper, selenium, thiamine, riboflavin, all the B vitamins, and also the fat-soluble vitamins to some extent. Jejunum is the area where we have all the B vitamins, then fat-soluble vitamins to some extent, calcium also to some extent, and all the other things as well. So these are the nutrients that will be absorbed in this region. And ileum is where the vitamin B12 and intrinsic factor complex is absorbed. So that happens in the distal ileum. Now, going on to each micronutrient, we start with iron absorption. Now, iron, once it enters into the stomach, it is reduced to the ferrous state from the ferric state. And gastric acid, so the hydrochloric acid, which is actually secreted by the parietal cells in the fundus and the body of the stomach, and ascorbic acid enhance the solubility of ferrous iron. So the gastric acid is actually important for iron absorption because it enhances the solubility of ferrous iron. And though the iron absorption happens in the duodenum and upper jejunum, but any surgery which will take away a large part of the stomach and reduce the amount of hydrochloric acid in the stomach will also have an impact on the iron absorption. So then once it's absorbed in the duodenum and upper jejunum, it is coupled with transferrin in the circulation, and then it is delivered to the cells of the body. When we come to vitamin B12 absorption, again, the first step is the hydrochloric acid, which lyses the bound form of vitamin B12 from food and its attachment to the gastric R binder. So hydrochloric acid is again important for releasing the bound form of vitamin B12. And then this binds with the intrinsic factor, which is again secreted by the parietal cells in the fundus and the body. So it is very important to form this vitamin B12 intrinsic factor complex, which can then be transported distally into the small bowel. And then finally, this complex is absorbed in the ileum. So one thing is reduction in hydrochloric acid. Second thing is taking away the parietal cells, which are actually secreting the intrinsic factor. So these are the two steps which, if they get hampered at the stage of the stomach, then vitamin B12 absorption gets hampered. So again, all our bariatric procedures will predispose our patients to vitamin B12 deficiency. Foliate absorption. Foliate is principally absorbed in the proximal third of the small intestine, and it's partly pH dependent. Very small amounts are stored in the body, and hence the body requires a constant supply. But usually the supplements that we give to post-bariatric surgery patients would have folate as a part of it. But yes, if the patients are not very compliant, then folate deficiency can also be expected because we don't have much of a store of folate in our body. Calcium and vitamin D3, again, these are absorbed in the duodenum and the upper jejunum. So all our bypass surgeries where we will be bypassing the duodenum and the upper jejunum will predispose the patients to calcium and vitamin D3 deficiency, and in turn predispose them to secondary hyperparathyroidism and high bone resorption, which can lead to metabolic bone disease. Thiamine, again, is something which is very important. It is absorbed in the jejunum by two processes: an active transport process when the thiamine level in the small intestine is low, and a passive transport process, which is when the high thiamine concentration is high. Our body does not produce thiamine and can store only up to 30 milligrams of it. And deficiency of thiamine can lead to dry beriberi, wet beriberi, Wernicke's encephalopathy, and eventually Wernicke's Korsakoff syndrome. Thiamine is not very difficult to treat. I mean, it can be easily treated. In fact, in India, we don't even run any tests for post-operative expected deficiencies of thiamine, because by the time we receive the reports, I mean, we've already started the treatment. So it's not very difficult to treat it. Then the other fat-soluble vitamins like A, D, E, and K, these deficiencies are expected in surgeries that are very malabsorptive. So a surgery like BPDDS, where we bypass almost the entire length of small bowel, these are the deficiencies that would be expected. Copper absorption again happens in the stomach and the duodenum. Going forward, copper deficiency anemia can also be one of the causes for anemia. And then we have zinc. So pre-surgery deficiency is known in patients with obesity. And we also have selenium, which is absorbed in the duodenum. So when we are talking about bariatric surgery patients, I think it is also important to keep these nutrients in mind because sometimes they can present with deficiencies, although they are rare. Coming to macronutrients, protein is mainly absorbed. The absorption is usually completed by mid-jejunum. So once dietary protein is taken, the protease in the stomach, basically pepsin, leads to the first part of digestion. And then, of course, the pancreatic enzymes like trypsin, chymotrypsin, elastase, and carboxylpeptidase, these help in further digestion of protein. And like I mentioned, absorption is usually completed by mid-jejunum. Fat absorption, so there is little or no digestion of fat which happens in the mouth or the stomach. We basically need the pancreatic lipase for the digestion of fat. And again, any surgeries which are bypassing the bowel will lead to fat malabsorption. And the more we bypass, the more the fat malabsorption will happen. Now, going on to the effect of bariatric surgery, there are multiple causes of nutritional deficiencies post-bariatric surgery. And these may not only be related with the anatomical changes that the surgery brings on, but it could be because of loss of appetite, which happens because of reduction in the hunger hormone level, which is ghrelin, and of course, a lot of other neurohormonal effects of the surgery. We also know that all our surgeries reduce the size of the stomach, leading to early satiety. So basically, there is caloric restriction, which is happening, and the amount of food that the patient is taking is definitely restricted. There is altered anatomy, and I will have spoken about it till now, and I will go into further detail about that. But patients can also develop food intolerances and food aversions, which I think all bariatric nutritionists would experience with their patients. Like I said, there is reduction of gastric secretion, especially that of hydrochloric acid, which has a major impact on the absorption of vitamin B12. It has an impact on iron absorption as well. Then there is also increased transit time. So if we are doing a bypass, it's quite obvious because there is nothing stopping the food to go into the small intestine. So it comes in the pouch and it just goes and dumps into the small bowel. But even after sleeve, it is known that the gastric emptying rate increases, and that doesn't give the food enough time to stay back in the stomach, and the trituration also gets affected. Some patients may complain of vomiting or diarrhea after bariatric surgery. Of course, more malabsorptive surgeries, patients will complain of more diarrhea. The GI bacterial overgrowth in the bypassed intestinal loops can also be a cause for deficiencies. And in the later period, complications like bleeding ulcers, like marginal ulcers, these could be another cause for anemia or iron deficiency in the long term for these patients. And yes, there is a need for regular follow-up that is required after bariatric surgery. Now, these are the common bariatric procedures. This is the gastric band. If we look at the anatomical changes that they bring about, the gastric band doesn't really change the anatomy in any significant way. It just divides the stomach. It's an external band which is put around the stomach in the upper part, dividing it into a upper smaller pouch and a lower larger pouch. We are not resecting the stomach. We are not rerouting the small intestine in any way. So the chances of having any kind of nutritional deficiencies is extremely low. When we talk about the sleeve gastrectomy, if you can see over here, we've divided the stomach vertically and we remove 2/3 of the lateral part of the stomach, and that comes out. So with this, we remove a very large part which has the parietal cell mass. So, I mean, there will be reduction in the hydrochloric acid levels, there will be reduction in pepsin, all the other intrinsic factors. So these cells will be reduced in number, and hence we can kind of preempt what kind of deficiencies the sleeve gastrectomy can bring about. This is the one anastomosis gastric bypass. Over here, we have a long pouch, a long vertical pouch of the stomach, and most of the stomach is bypassed. We also bypass the duodenum, we bypass the first part of jejunum, and of course the limb length of the biliopancreatic limb, that is the length of the jejunum that is bypassed, can vary from 150 to 200 centimeters, depending upon the patient profile and the surgeon preference as well. So in these two surgeries, the Roux-en-Y gastric bypass and the one anastomosis gastric bypass, not only are we reducing the size of the stomach, which means that we're taking away the parietal cell mass, we're taking away the cells from the antrum and the pyloric region, but we are also bypassing the duodenum and the first part of the jejunum. And when we go on to the duodenal switch, it is basically a sleeve, and then we bypass almost 90% of the small bowel. And we have a very short common channel. And this leads to a very high degree of malabsorption. And these are patients who will have a lot of nutritional deficiencies if they are not on proper supplementation. So if we can see in ascending order over here, as the intensity of the surgery in terms of restriction and malabsorption increases, so does the chance of developing any kind of nutritional deficiencies. So the common mechanisms which we have kind of discussed till now would be restriction. So all the surgeries will lead to restriction of food intake, and caloric restriction will happen. Gastric acid reduction. So hydrochloric acid reduction happens in all these 4 surgeries except for gastric band. Intrinsic factor is reduced in almost all the surgeries. There is bypass of duodenum and jejunum in all the bypasses, so except for the sleeve. And of course, increased gastric emptying happens, so which happens even in the case of sleeve, and of course in all the other bypass surgeries and the DS. Now, so once we reduce the size of the stomach, the reservoir is reduced, trituration of food is affected, hydrochloric acid will have an effect on the iron absorption. Intrinsic factor reduces, which has an effect on vitamin B12 absorption. Enzyme secretion is reduced, so pepsinogen reduces, and it can also affect protein absorption, which can be seen even after a sleeve gastrectomy. So protein absorption is affected to some extent even after a sleeve gastrectomy, and gastric motility is affected. So food passes down in the undigested form and much faster. So any surgery which is leading to reduction in stomach size will lead to iron, protein, and vitamin B12 deficiencies for sure. And these need to be looked at. When we are bypassing the small bowel, there are changes in biliary and pancreatic functions. There is alteration in GI transit time. There is bypass of duodenum, which is a primary site for absorption. Because there will always be a loop, which is the biliopancreatic limb, which will have some extent of small intestinal bacterial overgrowth. So that can also be additional cause for deficiency. And then deficiencies of fat-soluble nutrients or nutrients absorbed in the bypass section of GI tract are also seen. So in bypass procedures, the deficiencies that can be expected would be almost of everything. So iron, calcium, folate, vitamins, fat-soluble vitamins, protein, fat, zinc, copper, selenium, and so on. So if we see over here, this is the sleeve. The expected deficiencies will be iron, B12, and protein. And hence it is important for the sleeve patients to be monitored in the long term for these deficiencies, and at least a yearly follow-up with all the labs are expected after sleeve gastrectomy also. This is a gastric bypass. Whether we talk about a Roux or a one anastomosis, they would all have similar deficiencies. The one anastomosis could have a little higher quantum of deficiencies depending upon how much of the jejunum has been bypassed. But yes, they will both have iron, folate, vitamin B12, calcium, vitamin D3, B vitamins, zinc and copper, and proteins, and fat to some extent, and fat-soluble vitamins to some extent. But usually with our routine supplementation, these can be kept up. A duodenal switch, in addition to all the other deficiencies that we see in Roux-en-Y and 1 anastomosis. Number one would be that the quantum of deficiencies will be much higher, and hence the dose of supplementation of each nutrient is also almost 200% of the recommended daily allowance. And additionally, there is a lot of fat malabsorption, and hence we have to be very, very careful about the fat-soluble vitamins, which are A, D, E, and K. So in conclusion, what I would like to say is that if we are into the field of bariatric surgery and bariatric nutrition, it is very important for us to know the anatomy of bariatric surgical procedures along with the physiology of nutrient absorption, because if we know that, and if we are very clear about what is absorbed where, I think we can pretty much tackle any kind of a bariatric procedure. In addition to the procedures that I have discussed today, there are many, many newer procedures, and in different parts of the world, different kind of procedures are practiced. But if we know the basics, I think it is basically like mathematics, that you can judge what kind of deficiencies are to be expected. It is also important to take cognizance of the pre-operative deficiencies and dietary preferences of the patient. So we cannot be imposing ourselves on the patient. So just to reiterate, like somebody just asked about keeping our patients on lifelong diet. So patients need to know what to expect. The procedure must be discussed with them pre-surgery. The demands of the procedure must also be discussed with them pre-surgery, because at least in my practice, if people are not up to taking supplementation and they are, they are upfront about it, then we give them time to think and to make up their mind, because if we do a bariatric surgery and they're not good with their supplementation, then ultimately they are the ones who are going to suffer. And of course, lifelong review and follow-up is required after all bariatric procedures, whether we're talking about a sleeve gastrectomy or gastric bypasses, of course, the duodenal switch and everything, but definitely more so for bypass procedures. But it is, in terms of nutritional deficiencies, all bariatric procedures can be potential causes for long-term nutritional deficiencies. Of course, supplementation may vary in dose and frequency by procedure, but it is lifelong for all bariatric operations. And with that, I would like to conclude my talk, and thank you all very much. Just stop sharing my screen. Thank you.
Thank you. I got one question.
Yes.
Because after bariatric operations, usually we are concentrate on GI tract as a way of absorption of supplementations. But most doctors probably, we are forgetting about the skin, like for vitamin D or microelements. Are you aware, or have you heard about any like trials for bariatric patients to use that way of absorption of vitamins or minerals? Phototherapy?
Absorption through the skin?
Yes.
Okay, I'm sorry, but I haven't really heard of any trials which are at the moment going on for that. Probably my other AHP colleagues would be more familiar with something like that.
Thank you.
Thank you.
There are some questions for Dr. Denise Radcliffe. Do you have any tips on how to identify patients who need psychological input assessment before surgery?
So most services would use a screening approach, so that might involve either one of the other MD team members as part of their assessment asking specific questions about psychological issues, so some basics or some mental health questions or some eating questions. The other approach is to use a questionnaire in clinic, which is something that I've tended to do. I think actually one of the perhaps more helpful things though alongside that is to actually ask the patients if they would like to have a psychology consultation, because actually a lot of people identify that this is a psychologically challenging process and would like the opportunity to think about it and to seek some support. So I think it's not just about us identifying people, it's about offering people the opportunity as well.
Another question is about the time frame. What time frame is considered for the best point of behavioral change, before, early, or post-operation?
I think ideally, I'm going to hedge my bets with this, but ideally you would want a bit of both. So it's obviously helpful for patients to have some pre-operative input in order to prepare and make changes so that it's not too stark a contrast. But if people are starting to struggle post-op, then obviously you want to intervene quickly, and the evidence would suggest that that's more likely to have an impact on outcomes as well. But ideally a bit of both.
Also, high recommendation for all patients to read your book, as we mentioned.
Thank you.
And the questions, yeah, my turn.
Oh, no, I'll just, yeah. I think, shall we, I think we're going slightly into refreshment breaks at the moment. Do you guys want to answer any more questions, or shall we have a break now?
This question from Dr. Aparna: how much information do you personally give to your patients about this nutrition? Also, do you use this information in helping to educate the young doctors in training or AHPs?
Yes, so the second question first. We do train the young dietitians, and we run a course every year. The course is going on right now. It's a 2-month course about bariatric nutrition. It's online, so that's one. And as far as giving information to the patients, I think it is extremely important for the patients to know what to expect and what they are getting into, because it's human nature that after a few years, it's like any other chronic disease. So the patient compliance goes down as time passes by, and hence the intensity of follow-up has to go on increasing. But at the time of first consultation and the second consultation, we do inform them that, yes, if we are going to do these surgeries, you will be subjected to these lifelong supplements. And it has to be done in a way that we don't scare them off, but also drive the point home that it is important for their health in the long term. Otherwise, there can be a lot of issues. So issues with bone health, issues with anemias and things like that. So I think it's not just about one consult, it's about repeated counseling effort, which happens not only before the surgery, but continues in the post-operative period. So it's a lot of work which needs to be done with patients who've had bariatric surgery.
Thank you very much. I think we run over the time. Let's go to refreshment break. Okay. Thank you for participation.
Thank you.
Thank you, everybody. Cheers.